Good morning, everyone. People are coming on in, but we're going to go ahead and get started because we only have an hour, and I want to make sure we have enough time to get through all the good that Wendy has to offer. So my name is Lori. I'm the Alliance's Outreach and Communications Manager. Before we start the training, I'm just going to do a brief intro of the Alliance and go over some housekeeping. So the Alliance is the leading national nonprofit organization providing education, referrals, and support for all individuals experiencing eating disorders. Currently, we have 12 virtual and 7 in-person free weekly therapist-led support groups. We provide support and referrals for all levels of eating disorder treatment through our free therapist staffed helpline and through finddhelp.com, which is the largest free national database for eating disorder clinicians and treatment programs. A few upcoming events. We have our next free Friday morning training this Friday, July 25th. It will be on navigating performance pressure and disordered eating in sports. And for a few housekeeping for today, in order to receive CEs, we are going to offer one CE for this. You will need to attend live and complete the program evaluation, which I will put in the chat toward the end. It will also be sent in a follow-up email tomorrow in case you miss it. Completion certificates will be sent out in about a week after you complete the program evaluation. These are not sent automatically, so please be patient as they make their way to your inbox. Make sure to check your spam or junk folder in case you don't see it in about a week. If you have any questions throughout the webinar, please submit them in the Q&A section. We're going to answer them at the end. We will be sharing a recording of today's training via email. So thank you again for joining us. I'm going to toss it over to Ryan, who will introduce Dr. Wendy Oliver-Pyatt and Within.
Thank you so much, Laurie. Welcome, everyone. For those of you that are back for round two, we're excited that you're joining us. For those of you that are here for the first time, we're really looking forward to getting into this discussion. I want to first just thank the Alliance for your hospitality and coordination in making this discussion happen. There was so much excitement around the first one. We were really excited to be able to come back and hang around for round two. My name is Ryan Sobis, and I am a clinical outreach representative here at Within Health. And for those of you that are just getting to know Within, if you want to jump to the next slide.
You got it.
Thank you. Within is a physician-owned and led by this amazing human here. And we are an intentionally remote intensive outpatient and partial hospitalization program treating all diagnoses of eating disorders. A few things about Within: we're dedicated to evidence-based and measurement-based care. And we are able to be active currently in 40 states. Our reach in terms of insurance programs are expanding by the day, and we're really excited to be able to continue to expand our access to care to folks nationwide. We are able to provide care for 3 different age milieus. Our Within Z program supporting adolescents ages 13 to 17. We have a Within University program supporting university-aged and graduate school-aged students, as well as our adults and mature adults program. And a few other things about Within in that we have specialty programming that's really geared to support underserved populations, including men, adult women, BIPOC, LGBTQ+, really just making sure that there's a home for everyone and that they're getting individualized care. So for those of you that want to learn more about Within, I'll make sure that you have my information below, but we will jump over and introduce you to our speaker today. We have the pleasure of learning from our co-founder, CEO, and Chief Medical Officer, Dr. Wendy Oliver-Pyatt. She has over 25 years of clinical experience here in the field. She is a certified, board certified in both adult and addiction psychiatry, and has been named a fellow by the American Psychiatric Association. And just can't speak to the amount of impact that she's had here in the eating disorder field, developing more than 5 treatment programs across the country. She's an author of 2 books, most recently the Questions and Answers for Clinicians on Binge Eating Disorder. And so we're excited to be able to learn from her. And Throughout this presentation, please feel free to put any questions that you have in the chat. We'll make sure that we have time at the end reserved for questions, and just grateful for you all to be here and to spend some time together.
Thank you. I'm so, so blessed, as you all can see, to be able to work with Ryan. Such a beautiful speaker and so passionate and knowledgeable. She is a dietitian in her background. So I always find people that are doing outreach for us who have that clinical background to be, it's just especially meaningful, because she can really dive deep into the clinical predicaments you're all in. And if you do have any patients that are on the fence or white knuckling it out there, please call Ryan. And we're so grateful to Lori and Joanna and the Alliance, our partners in battling eating disorders, right? We work together so beautifully, and I'm really touched by that. And I want to thank everybody for coming today. It's very interesting to me to even be presenting on these GLP-1s because, I'm here navigating this along with all of you. This is something that sort of just came our way, and we were like, oh crap, what are we going to do? I remember the first time we got a call about somebody was pursuing treatment that was on semaglutide, and it was like, what are we going to do? And I decided pretty early on, we're not going to cut people off from treatment and say we aren't going to work with you if blah, 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 So we've definitely been learning as we go. So I'm as much of a student of this really as probably all of you in this call. So which is one of the reasons why I'm excited that we are able to have this follow up because we do have some clinical predicaments that, I'm really eager to hear how you all process these because I keep running into these clinical predicaments and I find there is really no perfect answer so often. I've had some really interesting predicaments come my way for sure, and some really blatant cases of people being misusing this medication with really deleterious and life-threatening consequences as well. So from the first talk, we set this talk up with really looking back at intentional weight loss as just a reality of human existence, going way back. It was actually Shavice Turner that came up with this idea, and it's the concept of like thinking of GLP-1s in that context, because I think there's a tendency to think, "Oh, this new thing came and it's going to just change everything, and it's like the big beautiful, whatever, not, it's the new thing, and people get all excited about it in and outside of the field, and thinking of it in the context of history, I think, is helpful. It's like another intentional weight loss mechanism. Yes, it's different, but at the end of the day, it is still that. So how we're going to talk about just that in general and how to navigate intentional weight loss with reverence and diligence. And I decided for this talk, following the last talk, I really thought it might be helpful for us to all kind of get aligned around like, okay, what is actually informed consent and risk benefit analysis? It's something we get trained upon in medical school. I'm just not sure that doctors are really, navigating GLP-1s with informed consent and risk benefit analysis being done. And I think that's really where the problem lies. So we'll talk a little bit about that and present some clinical predicaments and do some Q&A. I'm giving myself a little grace to bounce around a little bit on my presentation today because I condensed it and moved things around. So I've never done this version. So pardon me if I end up moving around a little bit just based on time. And I do want to make sure we get into the clinical predicaments. So just to kind of point out that going back to ancient Greece in the early centuries AD, there was already intentional weight loss was already a thing. And it was seen in these early writings about it as like being able to lose weight, and anorexia itself was sort of glorified in some kind of way as almost a state of being above others, of defying needs was sort of glorified in a way. And you can certainly see that throughout history, and in the field itself we struggle to this day with the stigma of, a person that has an eating disorder that's resulting in weight gain or binging and purging, like that sort of seen as like sort of less important, I think, or less severe of a condition unless the person has lost a lot of weight. And we have, a very big problem with that in our field. And I think I think the research shows that only 6% of people with eating disorders have like sort of classic restricting anorexia nervosa. And I always talk with families about this, is that a lot of times when you're working with family and loved ones, like they're very reactive if they're, and I don't mean to be like generalizing too much, but people tend to be very reactive. Oh, my daughter or my son, like he's binging and purging, and everybody's very alarmed. But like when they're losing weight or restricting, like if a loved one like binges and purges on like Friday at 4, everybody's up in arms. But if they're restricting, it's like it just kind of slips by. It's like, oh, they restricted, they restricted, they restricted. It doesn't like scream as loudly. And I think that there's a way that is tied in with weight stigma, and that is tied in with this like these earlier ideas of some kind of like moral superiority around being able to like deny your needs. There's something about being able to deny your needs that gets sort of like elevated. Of course, it's not really denial of needs. A person is getting their needs met in some way, shape, or form through the eating disorder, as much as it may be overpowering them and unconscious and beyond their capability to control. But the eating disorder, I think we always have to search for what the function is, whether it's soothing, whether it's comforting, whether it's avoiding, whether it's dissociation. I think that, I like to put up this slide in some of my talks. It's a sort of, it's an honoring of my mom, because I remember when I was a teenager and kind of doing my teenager things. And I remember my mom said this to me, the road to hell is paved with good intentions, and I think it's just important to remember that, socially sanctioned institutions, medical institutions, schools, doctors, dietitians, at government agencies, endorse intentional weight loss as this like wonderful thing that we should all be doing, and it actually equates with health to lose weight. And so my mom used to say, Wendy, the road to hell is paved with good intentions, and I'm thinking to myself, Mom, boy, you were right, and it really, really shows up with eating disorders, and I think it definitely shows up with GLP-1s. This talk, by the way, I should say something before I go any further. Um, I want to just share that this talk is not about casting moral superiority between one group or another, whether you use them or don't use them, or somebody in recovery is taking them for some reason and they've thought like, I'm not here to say I know better than the next person about what's right or wrong for any given, person. Certainly if I'm your doctor, or if my team is providing you medical care, like it's our job to have the process of informed consent. It's our job to weigh risk benefits. Like that is our job. But it is not my job, nor do I have the desire, willingness, or entitlement to tell anybody, what they ought to do. Because I put a post on Facebook, or one of those social media, about something that I came across that had to do with vision problems related to GLP-1s. And I was like, this isn't good. People don't really know about this. So I put it on one of my social media things just to share it. And I definitely had a negative feeling about it. I was like, damn, like they came out with this and like people don't even know this, and this isn't good, but it did actually cause some pain, I think, to some of the people who had really thought about it and were in recovery and were taking the medications for whatever reasons. And so I think it's important to kind of press pause and not feel like, just kind of convey like that we don't, like, I don't know what's right for any person really, other than I try to do what's right if they're my patient and I know the situation really well. I just want to, I think with this, just like really create a space where we can talk about it. And I do believe though that risk benefit analysis and informed consent is very important. And I think it's largely not happening with these medications. I think it's much less, I think it's almost rare, that informed consent is actually really happening. And that does bother me. So we all probably know some of these different medications. The ones that we hear a lot about are Ozempic and Wegovy and Mounjaro. Those are the ones we hear most about. We do hear a little bit about Ribellis. So these are just some of the medications. When you look at some of the risks and side effects that they're following post-marketing, The one called liraglutide has a lot more like kind of signal as far as some potentially really dangerous side effects. But I just wanted to share, that when these medications come out, they're only studied to a certain extent before they're put on the market. So the best way I could explain this is when I was a resident in psychiatry at Bellevue, NYU, my second year of residency was the year that risperidol came out, which is an atypical antipsychotic medication that's commonly used. When the pharmaceutical, the rep came to talk with us, they gave us these little folders that were about like this. And they had a packet. It was a very pretty packet. You open it up, and it had day one risperidol was 1 BID, mean twice a day. 2 BID was day two, and 3 BID was day three. So basically, in 3 days, you were going to titrate your patient from 0 milligrams of risperidol to 6 milligrams of risperidol, and that's how they told us how to prescribe it. Well, if there's any psychiatrists or any of you that know much about risperidol or have had any experiences, going from 0 milligrams to 6 milligrams of risperidol in 3 days is going to cause your people a lot of problems, extrapyramidal side effects, like very serious consequences. But this was what they knew at the time. So what happens is after these medications come out, then the drug makers do have, you do have a way to report adverse events, and they're sort of gathering this information as it goes. So we are all, in a sense, in the midst of a human experiment right now with these medications because we don't really know. Right after I gave my last talk for the Alliance, literally that day in my inbox, I got a notification about this new study that was showing these eye effects and potential for blindness. And then a week later, because I'm on these email lists, I got an email box about how these medication can reduce the effect of oral birth control pills. I'm like, I didn't know that. Did anybody tell me that? No. So I'm trying to just like explain that just because something has been cleared by the FDA doesn't mean it's been thoroughly assessed. And that's where I guess we come in, right? Where we're trying to help people. Um, so these medications, they regulate blood sugar. They do delay gastric emptying and make people feel full longer. So in that case, it truly reminds me of working with a person who's under eating and that has delayed gastric empty and they feel full and they're like, I can't eat more. I'm full. Well, they really feel freaking full. I think the other thing to talk a little bit about is, and this kind of scares me, is like we're hearing people talk about, oh my gosh, they mute food noise. So what we hear and what I'm worried about is that they're going to get an indication for the treatment of BED. And I'm very worried about that because I just did a podcast about that, like reducing food noise, that doesn't mean you're actually solving, a binge eating problem. Like people with binge eating disorder are generally quite restrictive in their eating. All you have to do is bring one into your treatment and see how they eat. Our patients are very restricted. We have to like insist that they eat. Um, so reducing the food noise and making them less conflicted about not eating is absolutely contraindicated. And I'm very worried that in the field, especially because of weight stigma and especially because of people in larger bodies who are very restrictive, which is a very real thing, I'm worried that people will think of this reduction as food noise as some be all end all wonderful thing. And what's going to happen to people after they go off these medications? That's a question I also have, which is a whole thing. So we talked a little bit about this. The mechanism of action is, it's pretty simple, but it's pretty complicated in the sense that it's multifactorial. Like it's affecting your like right there in your organs with your stomach and your pancreas. So it's slowing the gastric emptying, right? It's increasing insulin and decreasing glucagon from the pancreas, right? But it's also going up to your brain too and reducing your appetite from your brain. So it's affecting, your gut-brain axis and affecting neurotransmitters within that process. So it's a pretty intense thing to take these medications. It may not seem like a big deal just take a shot. Although to me, I was saying this before, the idea of just like taking an injection like that has a whole meaning to it as well. But really affecting your brain and affecting your stomach and your pancreas, and I mean that's a pretty intensive thing to go ahead and do. So within your brain, it's increasing satiety, it's decreasing your appetite. They do have some increasing of energy expenditures property as well. There are cardiac manifestations of this with blood pressure, heart rate, contractility, and there is thought to be a cardioprotective piece. However, I think that is also it depends is what it boils down to, because there's also sarcopenia and reduced muscle mass, and I've had some case examples of people getting into big trouble who have cardiac failure issues that are being put on these meds for diabetes. We can talk about that. But here's just many potential side effects here, affecting your glucose, your adipose tissue, your muscle. It's a big one. And we already talked about the gut with gastric emptying and gastric motility. So these medications can cause a ton of different side effects. The most common really are just those standard GI effects of this nausea, vomiting, and diarrhea, but those aren't to be taken lightly. I mean, especially, I mean, any one of us, it's miserable, but certainly if you have an eating disorder, that's to be concerned. And then there's the effect of weight cycling. I feel like weight cycling never gets enough attention in the health the field of medicine in the first place. It's always like it's never about the weight cycling. But when folks go off these medications, like, they do stop working. So whatever effects they were having go away, generally speaking. So people then are going to weight cycle, and that is already what we see going on. And I think as a part of the risk benefit analysis, like talking about, hey, if you take this, how do you feel about taking it the rest of your life? Whether in reality on a practical level, on a financial level, because the effects do go away once you go off the medication. And weight cycling is very dangerous to your body. Losing weight affects a lot of pieces of your body. So you're not just losing fat as if fat is such a terrible thing. Fat is protective in our body. There's a reason we store fat. There's a reason fat exists. Um, and it's not just fat that gets lost when we lose weight, it's muscle. That's a very important thing. Muscle gets lost when people are on these medications, which could be anything from your biceps to your heart. Your heart is a muscle. And so that is an area that I'm very concerned about. I'm very concerned about osteopenia and osteoporosis, especially with the American Academy of Pediatrics putting in some recommendations for these medications in young folks. So there's a black box warning about the risk of thyroid C cell tumors and medullary thyroid carcinoma in humans, but there's no recommendation or even screening or monitoring for the emergence of eating disorders, and that blows my mind. I feel like we're looking, I feel like we're back in that era of when the US government was like sending like cigarettes to like the people in the military and stuff. I just feel like it's just I'm just dumbfounded by it. I just can't get it. I just don't get it. Um, then there's the compound medications like that's coming about now too. I just wanted to mention that. There are some lower costs associated with them, but there's really no monitoring of these medications. So it's something to be very concerned about when your patients are on that, because you don't really know what's going on as far as what they're actually getting in the dosages. So some of the things that are medically that need to be monitored, and I don't think this is happening in addition to the whole issue of eating disorders and muscle loss and that sort of thing, and osteopenia, osteoporosis, these other irreversible consequences. At least with osteopenia, osteoporosis being irreversible generally. But the monitoring, I'm not sure, is being done in a very succinct, in a very comprehensive way for most of these folks. But certainly monitoring glucose levels. We have a lot of cases of people getting hypoglycemic, very weak. Renal function, certainly dehydration is a very big potential side effect. Um, and there is an issue of pancreatitis, so we do want to be monitoring amylase and lipase. We need to be monitoring thyroid function. When people lose weight quickly, a lot of times that can affect gallbladder is also a thing to watch out for. Certainly orthostatic hypotension and tachycardia associated with dehydration are all things that need to be monitored. There's just a little bit. There are a little, there's the semaglutide and then there's tirzepatide, which is a slightly different medication. I thought I should just mention that. There's different profiles. There is this GIP activation with tirzepatide, and it does show maybe a little more weight loss potentially. So just something to be a little bit more careful about. Another thing to be careful about and aware of is that there's a lot of microdosing going on now, which you guys probably heard about that. Cynthia Johnson, who's VP of brand at Within, she sent me this video, which she just couldn't believe. It was on social media, and it was a doctor in a small little group of people, and there was a woman that was living in kind of a smallish body, and they were talking, and he was like, absolutely, yes, we can microdose for you. And won't that be great? And I mean, this was like normative. So I kind of get scared when I think of what is like normative to young people when they go onto social media and see that kind of thing. Because they're looking at a doctor who's like an authoritative medical, within the institution of like a reliable, authoritative um, thought leader or somebody that's putting out information that should be believable and is like reinforcing to somebody in already a small body that they should consider or that he would be happy to give this person some GLP-1s in a microdose. So I think this is something that we're really is going to be happening more and more. So I think talking about it and asking about it is going to be very important. Again, it doesn't mean with every single person that you're just going to come down on them and say, "How dare you?" That's not the energy we want to put out there. But we should know about it, I think, as prescribers. Um, so, what does the research really show about do GLP-1s cause, eating disorders? I think the research is limited, but this is where, lived experience comes in. And certainly I have seen from well, first of all, it just makes sense that yes, they absolutely either can cause or exacerbate. If you think about just their medical effects are really mimicking the medical aspects of anorexia nervosa, restricting that we're trying to battle, well, all eating disorders, but particularly the delayed gastric emptying, which can actually be seen across diagnoses. But and appetite, minimizing your appetite, reducing the food noise. Well, food noises means your body and your mind are sort of needing food that you wouldn't have the desire to eat if there wasn't a need for it. Um, so I think that it makes tons of sense that yes, they can actually exacerbate eating disorders. And I've absolutely seen this in my work with people that have had, and I'll get to that when we talk about cases, people with histories of eating disorders getting put on these medications. All right. There's some expanding therapeutic horizons that are being talked about, particularly the alcohol use disorder, I think is very interesting. Um, some people with PCOS think might be some metabolic support there. There's some early signs on cardiovascular health, but I've seen in practicality the opposite, and those cardiovascular benefits go away upon, being off the medication. These are not going to go away. These medications aren't going to go away. And there's other elements of these medications being on the market that I think, just have to kind of pay attention to because our patients then are potentially, I think, going to be like, oh, well, it's okay. I'm on these medications because I'm signed up to my, daily harvest, whatever meal plan, and I'm going to get support with my protein shake or whatever. So kind of like cutting corners there with the idea that there's a way to sort of combat. And I know there's some new medications coming on the market that are said to reduce the sarcopenia. Um, so we talked a little bit about some of the hazards there and the medical monitoring. Um, so now I want to move into, because it's at the half hour time, I do want to move into a discussion of the clinical predicaments. But I think what I'll just do is take a quick peek at the chat before we do this to see if there's anything I want to address so far. Any questions? Nope. It all looked kind of more on the practical side. So, all right. So here we go. Clinical predicaments. So I wanted to share some clinical predicaments that have come up that I've encountered, and there's another one that just came my way recently too. And then maybe we can have a little bit of a discussion about it. So what I thought I would do is I'm gonna share these predicaments, right? Then before we even have the discussion, I want to quickly talk about informed consent and risk benefit analysis because I think we need to have that in the back of our mind when we're thinking about it. So I'll present the clinical predicaments so you have them in your mind, and then we'll go through the informed consent risk benefit analysis. Because I was thinking, in medical school they're teaching this to us, even though I think a lot of doctors don't always follow it, but we're supposed to adhere to this. And I just want to make sure the audience, we get a chance to kind of go through what that is. So here's the clinical predicaments that we can all sort of think about. Then we'll talk through what is informed consent and what is risk benefit analysis. And then we'll come back and we can kind of chat about it. So the first predicament is a 55-year-old. I call them also dilemmas. A dilemma is like you don't know what to do. It's like you're just sitting there going, it's a dilemma. There's not always a right or a wrong answer when we're in this world, right? 55-year-old woman with a past history of PTSD and BED who underwent treatment, their eating disorder treatment, by the way, largely had a very positive response to treatment. The patient was experiencing mobility issues and had a elevated hemoglobin C. This is actually a true case that we had at Within Health. And so, how do we feel about this person going on to treatment with a GLP-1? That's a real case. And after we talk about it, I can tell you what happened to that person as well. And she gave me permission to discuss it. I won't disclose anything else about her that would share, anything private. So the next one is a 23-year-old college student with a history of bulimia nervosa and alcohol use disorder. The patient is on a GLP-1 and reports alcohol use has improved. She presents for admission to eating disorder care, but she will not stop her GLP-1. Patient feels the medication has improved her binging, and she will not stop the medication. She was referred by her college student health center because she was purging. Okay, so she was purging in college. She did have alcohol use disorder, and she felt the medication was helping with the alcohol use disorder, and she wanted to come to treatment, and she wasn't going to come off the medication. Do I admit her? What do I do? You tell me. What do you all think? I would like to know what you think. Um, so here's another patient, a female living a larger body, no prior eating disorder, however, was a very picky eater, is a very picky eater. Okay. Almost bordering on ARFID, but not quite, but bordering. The person had very significant mobility issues and hypertension. But she came and she was like feeling a lot of weakness, not feeling good physically, but she feels like it's improved her quality of life. And the reason why she felt it improved her quality of life was because she felt like this person felt like the weight loss improved her mobility. So again, here's three dilemmas here, three clinical predicaments that you can just kind of think about. And if you all have any of your own dilemmas or predicaments, then we hopefully can have chat about that a little bit. So I want to talk through what informed consent is and what a risk benefit analysis is, because I think that this is what's really, really the missing link with these medications. And really, I was talking about informed consent 20 years ago when I was first doing my talks on diet culture. And because doctors prescribing, I would say, look, if you're prescribing a diet, that's a medical intervention. So did you do a risk benefit analysis before you recommended that to the person? And the answer generally is no, because as we know, dieting most likely causes weight cycling and can be contributory to eating disorders, but doesn't cause permanent weight loss, as if that was a healthful thing anyway. But um, So I've been talking about informed consent for a while, and I really think that it is so relevant now. The other thing about this that I just want to share is that who it is that can prescribe this medication is quite problematic. I was sharing with Ryan and Lori, I was thinking about this morning. I know somebody that's getting chemotherapy right now, and I had a little question about a decision that was made on the chemo. And I was thinking to myself, wow, I would never prescribe chemo for this. I would never but I could with my medical license, I could actually prescribe chemo because I have a medical license. And I was thinking it's the same thing with these medications. Like many of the physicians that are prescribing these medications, they have literally no knowledge about eating disorder. And also very few, like they don't understand weight stigma, they don't understand eating disorder, they are not necessarily thinking about what's going to happen in the long term. They don't know what weight cycling is. So it's very problematic. So informed consent. It's the process of providing the patient with the information that they need about what is actually going to be presented to them for treatment. So it's a voluntary and educated decision. That's something that we really just have to keep in the idea that it's an educated decision. So are folks really getting informed consent? It does protect autonomy. It ensures that decision making is voluntary. It meets ethical and legal obligations, and it does build trust to provide informed consent. So everything's slowing down and writing informed consent is very, very important. So it involves disclosure, like really an explanation of the risks and the benefit. It involves comprehension, like the person has to be able to understand it. I mean, even when you're doing in psychiatry, we do have to do informed consent if somebody for example, when sometimes people want to come into our program and they only want to do IOP, they're not willing to do PHP. We run into this all the time. And so what we do is we try to recommend what we recommend, and we don't always say no, we won't admit you unless you do blah blah blah. But we always do try to provide this informed consent, and we try to talk people about like our decision tree as to why we're recommending it. It involves voluntary. It's a decision that somebody makes freely. It involves competence. The person is competent to make the decision, and it's an explicit agreement to proceed with the treatment. It can be written or verbal. And also the other thing, it's not a one-time event. It can be opening an ongoing thing. So there was a case I was working on where the person was put on the medication, but at first everything seemed to be fine, but then she was getting weak and weak and weak, and her blood pressure was actually lowering down. So it has to be something that's not just one time. Whoever's prescribing has an ethical, moral, and legal obligation to be monitoring on an ongoing way. And it does respect human dignity and rights. It does reduce the risk of legal claims, and it does enhance patient satisfaction and trust, and it upholds professional ethics. So it is a very important process. Again, the word is process, and it's central to ethical and legal healthcare. I think in our society these days, there's, not to get off on a political sidebar or anything, but there's this, it's sort of like due process, right? We have a right to kind of know this is part of what makes our society the society that it is like understanding the risks and the benefits and being informed and having there be a process so that people are voluntarily making decisions on their own merit after they have the information that they have. So informed consent is very tied to risk benefit analysis and medicine. So a risk benefit analysis is is a way to reduce the harm in clinical decision making. So often when we're doing any intervention, we don't necessarily sit down and go, what is the benefit and what is the harm? Um, and we might proceed with harm when we think the harm is really, really high or the benefit is really, really high, whatever the case may be. But it's really a ratio there, and it's very important in clinical decision making. It's actually something we deal with a lot in our treatment of eating disorders. Um, so the key things is that we all need to understand what the components are and how it applies in practice. So it's evaluating benefits of a medical intervention against its potential risks or harms to determine if it's justified for a patient or population. It upholds ethical principles, and again, this is what supports informed consent, and it personalized decisions for patients, where we identify the risk, the benefit, and we have to kind of quantify that and consider patient values and preferences and make a shared decision. They can be quantitative or qualitative. It could be different. One person, it could be the same clinical scenario, and one person wants to go this way, one person goes that way. And that's okay. And it's an ongoing event. It does also, informed consent is something that actually, I'm sorry, the risk benefit analysis is really the job is before we as providers suggest something, before we go through informed consent, we as providers have to already have done our own risk benefit analysis. So I shouldn't come to a patient and say, hey, let me give you the informed consent about this unless I've done my own as a practitioner, done the risk benefit analysis. So again, like if I'm not going to prescribe chemo for somebody, right? I would let that be the chemo doctor, but the chemo doctor isn't going to come and suggest or pursue informed consent with chemo that has very low likelihood of being effective, and very high probability of causing death. They may really be like, yeah, that I'm not going to pursue informed consent with that. So the risk benefit analysis really needs to be done by the doctor to then pursue the informed consent. So now I'm going to just take it back to the clinical predicaments. And I really just want to open it up, for discussion. And I hope that you all will be willing to participate. All right. So we've got a response here from Leah. She said, what I have found especially difficult is that even when I have seen patients on GLP-1s who seem to have been given a good amount of information around some of the potential side effects and nutritional implications of the medication, the weight stigma piece is completely missing. The doctors prescribing this often seem so uninformed about weight stigma and are so deep in traditional thinking that weight loss is always a worthy goal. That is very, very true, and in the pursuit of health. Interested in your thoughts, Leah, on these clinical predicaments. Byrne says, and patients often like the idea of seeing more immediate feedback changes and it can seem like less work. Sadly, a lot of people use this as a strong basis of the decision, almost diminishing the risks they have named. Yeah, very difficult difficult. Kelly says, very difficult for clients to hear consequences, especially when the MD says it's okay. Yes. So, is there anybody that wants to chime in or talk about this first one? Any thoughts about, let's say this person walked in the door of your office, and they had a history of BED, largely had a positive response to eating disorder treatment, was taking this medication, had lost a bunch of weight, and was feeling pretty good about it. How would you approach this patient? Anybody want to share? I can certainly share what I did. So what I did in this case is, this is a person who had been in treatment at Within, and I had contact with her clinically post Within for reasons I won't go into right now. But so this patient felt that because she had had very, very good, thorough eating. She actually was in treatment for many months. She felt that it was really beneficial to her to have been in the eating disorder treatment before she went on the medication, because she said if she had just gone on the medication, she would have been sort of euphoric about the weight loss that it was causing. There was a wise part of her that was knowing that I think there was a part of her knew that the weight loss might be temporary, and it turned out that it was. She did eventually go off the medication and gain significant weight back. Um, but she just didn't want to keep being on the medication, and she did start to feel like she did feel weak. She liked to play pickleball, and she felt it was making her weak, and she tired of the medication. She gained weight back. She felt that by having been in the treatment and had worked very much on improving her, I think first and foremost, self-compassion and self-esteem, and not having her sense of worth be so locked into her body size, that when she was on the medication, even when she was off, it wasn't catastrophic. I think if she would have not, and she said this, if she had not had that treatment and not done a lot of work around that, she would have been, euphoric around the weight loss and then incredibly dysphoric when the weight came, back in. So that was just kind of like what actually happened with this person. So the person did lose weight, had improved mobility. I think she would say improved quality of life. She did gain back weight going off the medication, but she's doing okay. She really is doing okay. I think overall her quality of life has been quite a bit better. But she says that if she had not done the treatment before being on the meds, she would have been sort of like hoodwinked into it. Okay, I'm looking at some of the other piece. Very difficult. Okay, I believe in the second one, the college student is purging, right? So Rebecca said, I think for me, I'd prefer to work on the behaviors of picky eating, purging. Okay, so you're talking about the third before getting into the GLP-1s. Yes. Joy says, I see a lot of clients like this. A lot of it is validation, holding space for their process. I offer tons of psychoed and my concerns on how we might manage what happened. That's beautiful. Very beautifully said, Joy. Um, Allison says, I imagine I would educate regarding weight, stigma, and cycling, and eventually work on the trauma so that they were able to see the connection, able to connect restriction with PTSD. Yeah. As a therapist, I try to stay away from medication recommendations, but I feel like I would weave in how a GLP-1 could be playing into the role of her ongoing eating disorder and PTSD. Yes. Okay. So that was the first case. The second one, so this one, she refused to stop the medication, right? When she came in. Well, this one is a case where the medication was helping her with the alcohol use she felt. However, the binging and purging was very tied in. It turned out that the binging and purging, of course, shocker, was tied into restriction. So she also got tired of taking the medication. I think there is a fatigue thing that happens. The idea of like, again, taking any medication every single day is a pain in the neck, but like a shot every week. So she kind of faded out with that a little bit, and going off the GLP-1. She still for a while was continuing to binge and purge, but it did help a great deal. Just the a little bit of weight restoration and like insisting on meal completion, and because I think the binging and purging was not shockingly tied in with restricting. So we were able to get her to eat more regularly, and then she actually overall did really, really well, but she did end up going off of the GLP-1 and did okay with. She still had binge drinking on the weekend. It wasn't totally gone, but and there was a lot of education and work around the alcohol use disorder, positive family history. There's still a lot of risk there. I think with this one too, that whole idea of there being a panacea, of like, oh, my alcohol use disorder is gone. I think we sort of had to work around that too, of like, this is going to be work, like, this is going to be commitment, this is going to be, going to AA meetings for her. That was, a recommendation. So, taking away, I think one of the harms of these medications is like that whole like idea of there just being some beautiful answer that it's going to solve all our problems. And we just can't seem to escape, having to do the work. The one who had the picky eating, yes. Um, so it was a problem for this person. She actually was on semaglutide at first and kind of had a stagnation in her weight loss, which frustrated her. She didn't have an eating disorder, but she wanted to lose weight. And yeah, not everybody who wants to lose weight, maybe we don't agree with it, but it doesn't mean she actually had a true eating disorder. She was very much a picky eater, though. Um, so with her, she switched over to Monjaro, which still didn't seem to, she did have like a plateau as far as how much weight she lost. And she was really, she really had a problem with that. She was really frustrated by that. However, what we worked with her on was we worked on nutritional support. I think that's one of the big things with these medications is I've said this before. Much of it I think is tied in with like the risk benefit analysis really being thorough, the informed consent really being thorough, and then the prescriber being very intentional about not overvaluing weight loss as some sign of health. I think so much of the patient experience depends on did they have prior treatment or ongoing treatment if they're at risk for eating disorder? And then do they have one of us that's like checking on them, insisting they eat and nourishing themselves? And I think that's also what happened with all three of these cases. I think because they came to our attention, there was this energy around nourishing your body, nutrition, and the 45-year-old started getting some nutrition supplements because there was some kind of shake she got. I forget what it was, but and that I was okay with that. I was like, you know what? She's doing more on this end. This person is still struggling right now. Um, I think she might have gone off the Monjaro now. I'm not sure, but her weight loss plateaued. And thank God she didn't have a eating disorder because it was very frustrating her because she got a lot of positive reinforcement for the weight loss initially. And then it plateaued and she was like switching to Monjaro and still struggling, but having weakness. So it was like a sort of ongoing battle. Somebody asked me in the questions, Joy had asked me about what do I think about Vyvanse for BED. So I think it's kind of the same thing with BED. I feel like in my experience with BED folks with the Vyvanse, like so often the BED and has executive functioning things in it that are like tying in with self-care and nourishing your body and preparing food. And I think that's where some of the crossover happens with like Vyvanse. I feel like with BED, it's again a risk benefit analysis and there's no one size fits all. Like if taking Vyvanse like functions largely as like just an appetite suppressant, like that's not like what we're going for. We're going for self-care, compassion, and things that are more what I think are more how the Vyvanse helps with executive functioning issues that I see a lot in our BED patients. So these kind of things have to be monitored. I think it's not I don't tell everybody that, if they come to me on Vyvanse with BED, I'm definitely worried, I'm definitely pay attention. A lot of times I'll see that there's other indications just tying in with executive functioning, and there's so much crossover between BED and ADHD. It's just a whole world. So I think that's like what I see a lot of, but I think if I see a ton of restriction, I don't we really much, have to insist that people not destroy their bodies by lack of nourishing their body in all body sizes, of course. So you have to monitor that and make sure the Vyvanse isn't leading to heavy duty restriction and weight loss, which will of course result in very bad consequences. Ba, 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 ba. Yes, Leah said the picky eater is concerning, right? Because she's already restricted in variety, and she was at risk. She was at risk, and I think that's why she started feeling the weakness that you mentioned. Like she was not eating enough, and that's what happens. People don't eat enough who take these medications. You talk to them about it, it's like they are not eating enough, and they have to be like on meal plans where it's monitored. Okay, so how to maintain the nourishment with the medication? Yes, thank you, Gina. When you see people come off GLP-1, do you see their symptoms or behaviors increasing in comparison? What's interesting is that I've seen I've seen some of these people that go off the medication that I haven't seen like this like resurgence of like you've talked about that. I've seen people, it seems like they've sometimes had some effect from the medication that sometimes has been useful. Particularly with like hunger, fullness, awareness. I think the way that the body then just gets like when they're on the medication, like the hunger, I mean the fullness happens so strongly and so loudly. It feels to me sometimes when I've talked to some of these patients afterward that they almost have more interoceptive awareness afterwards. Again, my N is really small, but I have seen that happen. So I just wanted to share that. Have you seen that when a client is on GLP-1s for a long time and has known ED or disorder, i.e. binging, that in times of stress, they can once again feel out of control with food? Have you seen any increase in binging later on due to long-term use of GLP-1? I haven't seen that, but I do think that people going off the medications, if you've lost a lot of weight, you're gonna be hungry. You're gonna feel out of control and your body's gonna want to eat. So if you are really conflicted around that, I can see the pathway of rebound like binging. That's just how that's what I would expect. Um, and Dahlia says, in my experience, folks aren't counseled or provided with ongoing nutrition support to make sure they're getting. Oh my God, yes, that's one of the biggest things here. Is just the lack of education of people prescribing. I mean, that's again, I just use it like, would you want me to prescribe your chemo? Absolutely not. I won't prescribe these medications myself, just to say that. But I again work with people who what I try to do is if I see somebody on them and I'm involved with them, I want to do education to whoever is prescribing them. I personally don't prescribe them. Leah says it takes a lot of work to stay adequately nourished. True. Joyce says the scary thing is that they and everyone around them is psyched. They're not eating enough. And as you and others have mentioned, it's so hard to get them to sit with the idea that this is restriction. Very, very true. And Kelly says it's so normalized we should alter our bodies. Ugh, yes, isn't that not true? Well, we have just a few more minutes. Is there any other questions or Ryan? Do you have any other thing, Lori? Any other thing that you'd want to ask or share or comment on before we stop?
Yeah, thank you so much, Wendy. That was incredible. And thank you
You.
everyone in the chat for participating. We did have a question in the Q&A.
Uh-huh.
Interestingly, a lot of women with PCOS who eat regularly and are not restricting and who are meeting their caloric and macronutrient needs still have food noise. Some have started GLP-1 and report not having food noise. I guess it's likely acting on the leptin, ghrelin, or
Hmm.
their organic levels of GLP-1. Any thoughts on this regarding the food noise piece?
That's interesting. I mean, that's where it's like this is why I think we have to check ourselves too clinically, right? We can't just come out of the gate and be bombastic about, oh my God, these medications are the worst thing ever and how, we can't take them and be really like reactive around it because like, we're still learning. I'm learning. And like you just taught me something that I wasn't aware of that people, you're talking about somebody that you're very aware of that's like, doing well, meeting their nutritional needs. You're paying close attention to it and you feel like if they feel like this is improving their quality of life, it's reducing their food noise. I mean, I'm not here to say how dare you or that can't be the case. I mean, I would probably question whether they're fully eating enough. Because I think I personally, my bias is that food noise is definitely connected to not having enough food. Like I think the noise is there because our body needs food. However, I don't know everything and I don't know, this is just not, this is new terrain for me. So I think just allowing people the space to be where they're at and support them and like share how like Joy mentioned like share how we feel about it. Share I think the more interpersonal we can get and just honest and transparent and real with people like, "Hey, I'm worried about this," or "This is what I'm thinking about," or "I'm not really sure, but this is what I'm worried about." Like using that language and just I think also mentioning and reminding people just because a doctor prescribed this for you doesn't mean that you actually did have informed consent. Just because somebody wrote this prescription for you doesn't mean we've really done the risk benefit analysis, and it is an ongoing process. So how about we keep looking at that together? And I think that's kind of the approach versus being, okay, this is what we have to do or that's what we have to do. I wish it was so simple in life, but it just isn't, is it?
Yeah, we have a few more questions if everyone wants to hang on for like a minute or two. Maybe we can get through these quickly.
Okay. Let's see. Do you mind reading those, Lori?
Yep, I will read them.
Perfect.
I've heard that GLP-1s have been found helpful in treating SUD. Is there any research that supports this?
That is ongoing. That's one of the future uses, like that's one of the cases that we presented, and that's something I think we should keep in our field. Let's keep paying attention to that and learning more about that as it goes. I'm signed up for Medscape, like I get like research as it pops up. So I'll try to put it if I see anything on it, I'll be putting it up on my all of my social media, and we'll keep doing webinars and learning about it and trying to share information as it comes in.
Next question. How do we find that balance of informing patients that their GLP-1 prescriber likely didn't properly inform them about concerns/consequences of these medications while not potentially impacting their trust of other providers, specifically
Oh.
eating disorder providers?
Ah! Lori, Ryan, do you have an answer? I don't know the answer to that one. Such a delicate conversation, right? I think time and time again as I've gone through this work, with you all, I've noticed that the more real we are and the more we share our own process and dilemma, the more we can sort through things. So I think sharing the dilemma, like, hey, I feel a dilemma right here. Like the person is like articulating this, and it's like, I'm feeling this dilemma because I want you to feel you can trust providers. And yet I'm noticing I'm feeling this way about this, and I'm thinking this way about this, and this is why. So it's instead of like coming to a person with some recommendation, like, I think you should do blah, 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 is more, there's so much predicament and dilemma woven into this. I think going into it from this is how I feel, this is what I'm thinking, this is what's bringing up for me, this is what I'm worried about, this is what I'm wondering, using that language, and then we together with our patients can navigate this in a really beautiful way because it's not easy, and how do we don't know the answer.
Yeah,
So
exactly.
mhm.
Exactly. Well, thank you all so much for joining us. Thank you, Wendy, for the amazing presentation and Within for being a great partner of ours. Just as a reminder to please complete the program evaluation that is in the chat. I put it in a few times. It will also be sent in a follow-up email today, tomorrow in case you miss it. Um, so yeah, thank you all for joining us. I hope you have a great rest of your week. And we hope to see you at a future Alliance event.
Thank you so much
Thanks
for having us.
everybody. Thanks Ryan for your support. Lori, thank you for allowing
Yes,
us to be collaborated with you. Appreciate everybody taking
absolutely.
the time to come today. Thank you all. Bye.
Absolutely. Thank you all. Bye.